Hello everyone, welcome back to the Medical Detective series. I'm Dr. Rupesh Karn. Today's case begins with a familiar label, acute psychosis, but very quickly the story stops behaving like ordinary psychiatry. The patient develops seizures, abnormal movements, unstable vital signs, and respiratory failure. This is a beautiful case that teaches clinical reasoning. So follow the clues carefully and do not jump to the final diagnosis quickly. A 23-year-old woman is brought to the hospital because of sudden behavioral change. At first, everyone thinks of acute psychosis or mania, but within 72 hours, she has a generalized seizure, strange facial movements, severe autonomic instability, and eventually central hypoventilation. So, here is the diagnostic challenge. What single illness can look psychiatric at the beginning, neurological in the middle, and like an ICU emergency by the end? So keep this question in mind. The key point is progression. A psychiatric label may describe the first scene, but it does not explain the whole movie. 10 days earlier, she had a viral-like illness with fever, headache, and sore throat. 5 days before admission, she became fearful and paranoid. 3 days before admission, she stopped sleeping, became aggressive, spoke rapidly, and heard voices. On the day of admission, she alternated between shouting and sitting silently. There is no psychiatric history, substance use, epilepsy, head trauma, pregnancy, or postpartum state. Acute psychosis is possible, but the speed and fluctuation should already make us cautious. If you were the admitting resident, this is the moment to write your first differential before the neurological clues arrive. This is the first pause point. A safe summary is a young woman with viral prodrome, rapidly progressive psychosis, fluctuation, and emerging speech abnormality. The red flags are not the hallucinations. They are the tempo, cognitive change, and fluctuating speech. Important mimics include HSV encephalitis, autoimmune encephalitis, toxic metabolic causes, non-convulsive seizures, lupus, porphyria, and Wilson's disease. So before repeated sedation, she needs medical monitoring and organic workup. A first episode of psychosis is not automatically psychiatric. The more abrupt and fluctuating it is, the more carefully we must search for delirium and encephalitis. On examination, she is febrile, mildly tachycardic, and saturating normally. She has no meningism and no focal weakness, but she is disoriented, with impaired attention and immediate recall. Initial labs, pregnancy test, toxicology, and CT brain are all essentially normal. So this is a common trap. Normal CT does not mean no brain disease. Many inflammatory, epileptic, and autoimmune brain disorders are missed if we stop here. The most important abnormality here is not a lab value. It is the bedside observation that attention and orientation are impaired. The next step is not simply more antipsychotic medication. We need MRI brain, lumbar puncture, HSV PCR, paired serum and CSF neuronal antibodies, and EEG. If HSV encephalitis remain plausible, a cyclovir should be started while the PCR is pending. A key principle is parallel thinking, not miss infection, but also do not ignore autoimmune encephalitis. So EEG is especially important because seizures and non-epileptic movements may coexist. This approach prevents missing treatment of reversible conditions. 6 hours later, she has a focal onset seizure that becomes generalized. After waking, she continues to have lip smacking, chewing movements, tongue protrusion, and abnormal posturing. It is tempting to call everything continuous seizure activity, but in this syndrome, true seizures can coexist with orofacial dyskinesia and dystonia. The test that separates these is EEG. Some movements may have no EEG correlate at all. So the question is not simply, is she moving? The question is, what is generating the movement? Continuous EEG shows diffuse slowing and true temporal electrographic seizures, but several facial and tongue movements have no EEG correlate, supporting dyskinesia rather than seizure. The EEG also shows extreme delta activity with superimposed fast activity. This pattern is not absolutely specific and is not always present, but in this phenotype it is a powerful clue. At this point, anti-NMDA receptor encephalitis should be high on the list. This is the point where doctors should stop thinking in isolated symptoms and start thinking in a syndrome. MRI brain with contrast is normal. This does not exclude autoimmune encephalitis. CSF shows mild lymphocytic pleocytosis. HSP PCR is negative, though clinical judgment still matters. Now she has psychiatric symptoms, speech dysfunction, seizures, dyskinesia, altered consciousness, and autonomic features, plus abnormal CSF and EEG. This satisfies the clinical pattern of probable anti-NMDA receptor encephalitis, while antibody confirmation is awaited. So remember that probable anti-NMDAR encephalitis can be a bedside diagnosis before the antibody report. The pattern is convincing and mimics are being excluded. Because of agitation, she receives haloperidol. Then she develops fever, rigidity, mutism, sweating, CK elevation, urinary retention, and dramatic heart rate and blood pressure swings. So neuroleptic malignant syndrome is possible now. So dopamine blockade should be stopped, but NMS does not explain the viral prodrome, cognitive decline, and seizure that occurred before haloperidol. The better explanation is severe autoimmune encephalitis with dysautonomia, catatonia, and a possible NMS-like complication. The clinical discipline here is to accept NMS as a complication without allowing it to erase the larger diagnosis. On day 3, she becomes drowsier while receiving oxygen. Saturation is 96%, but the respiratory rate is 10 and shallow. EBG shows pH of 7.29 with PaCO2 of 59. The chest is clear. This is hypercapnic respiratory failure from central hypoventilation. She was electively intubated for airway protection and ventilation, transferred to ICU and mechanically ventilated, while the team treated seizures, dysautonomia, and the underlying immune disease. This is one of the most dangerous ICU traps in the case because the monitor can look reassuring while ventilation is failing. The antibody report returns. CSF IgG against GLU-N1 subunit of NMDA receptor is strongly positive, and serum is positive too. Now the diagnosis is definite anti-NMDA receptor encephalitis. CSF positivity is especially persuasive, but the case is not complete. In a young woman, the next question is whether we are missing some pelvic tumor which may be driving the immune response. The search must move outside the brain. So at this stage, the first reveal is complete, but the final twist remains. Why did this young woman develop these antibodies? This patient underwent abdominal ultrasound, even though she had no pelvic pain, no menstrual complaints, and no palpable abdominal mass. Upper abdominal ultrasound is unrevealing. Targeted pelvic ultrasound is requested, even though pelvic symptoms are absent. So we are not searching randomly now. I want to clarify that. We are using the antibody, age, and sex to decide the most likely associated tumor in this case. Pelvic ultrasound identifies 2.3 by 2 cm complex echogenic lesion in the left ovary with a mural echogenic nodule and a posterior caustic shadowing. There is no significant internal Doppler vascularity, and the right ovary is normal. The impression is a small dermoid cyst, also called a mature cystic teratoma. So the image is illustrative. The report is the key. Now we ask, is this incidental or the missing trigger? The lesion is small enough that it could be easily dismissed, but in this clinical context, that would be a serious mistake. After ultrasound, MRI pelvis characterizes the lesion. It is a 2.2 cm well circumscribed left ovarian lesion. The T1 bright content suppresses on fat saturated sequences conforming macroscopic fat. There is a small mural protuberance with a calcific focus but no suspicious enhancement, ascites or lymphadenopathy. The impression is mature cystic teratoma. Ultrasound raised the suspicion, MRI confirms and helps with surgical planning. MRI also helps the surgeon to decide whether fertility preserving cystectomy is reasonable and whether there are suspicious features. The final diagnosis is ovarian teratoma associated anti-NMDA receptor encephalitis. So we must word this carefully. The CSF antibody result proves the encephalitis. Imaging demonstrates the characteristic associated tumor. Together with the patient's age, phenotype and tumor type, this makes the teratoma a highly plausible immune trigger, not a random finding. But imaging alone does not mathematically prove causation. The histopathology strengthens the link after surgery. The wording is important for academic honesty, for teaching residents. Now, how to avoid overstating what a case proves. A mature teratoma can contain neural tissue. That tissue may express NMDA receptor antigens. The immune system targets those antigens and the antibodies cross-react with NMDA receptors in the brain. They cause receptor internalization and disrupt synaptic signaling. That explains why manifestations are so broad: psychosis, memory and speech dysfunction, seizures, dyskinesia, autonomic instability, and central hypoventilation. The ovary is not physically attacking the brain. The immune system is the breeze. So this mechanism also explains why early treatment can lead to traumatic recovery. The problem is partly functional receptor disruption, not only irreversible tissue destruction. The first 72 hours are about preventing death and stopping immune injury. So needs ICU monitoring, ventilation, continuous ECG, frequent blood pressure and temperature checks, PaCO2 monitoring and EEG. HSV must be excluded and acyclovir given if plausible. First-line immunotherapy is high-dose methylprednisolone, commonly 1 gram daily for 5 days, combined with IVIG or plasma exchange in severe disease. Symptomatic care treats seizures, agitation, catatonia, and dysautonomia, but immune therapy treats the disease. The patient should not wait in the ward while these decisions are being debated. Severe dysautonomia and hypoventilation require ICU-level care. So for our patient, the clinical course was severe. She is intubated on day 3 for central hypoventilation. She receives methylprednisolone and IVIG, and once stable for anesthesia, she undergoes laparoscopic left ovarian cystectomy. Histology confirms mature cystic teratoma and mature neural tissue and no malignancy. So because improvement is initially inadequate, rituximab is added around day 8 to 10. Over the next 2 weeks, dysautonomia and movements decrease. Respiratory drive returns and she is extubated around day 17. She later requires neuro rehabilitation. The final lesson is simple. In a young patient with sudden psychosis, impaired memory or speech, seizures, dyskinesia or autonomic instability, think autoimmune encephalitis before calling it primary psychiatry. Normal CT and even normal MRI do not exclude it. In a young woman with anti-NMDA receptor encephalitis, search for an ovarian teratoma. Treat early, protect the airway, exclude infection, start immunotherapy, and remove the tumor when present. Thank you for watching. Like and subscribe. Thank you.